Everyone, thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's very good to be with you today. I'm excited for this session on considerations and complexities for data communication. And we're just getting right into it. I'm going to introduce our organizer and moderator, Helen Figge from MedicaSoft, who is also a NADO board member, will be moderating today's session. So Charles, let's go ahead and bring Helen to the stage. And Helen, take it away.
Well, thank you everyone for attending this, this session. We're very excited about it, the considerations and complexities for data communication. As Norm said, I'm a board member of NADO. I strongly encourage everyone to get involved in the organization because at the end of the day, anything that is relevant to healthcare or any of the policies relies on reliable, unbiased data of which NADO supports and is passionate about. This is a session really about the considerations of communicating the data. It's really exciting to collect it, analyze it, but at the end of the day, we have to be able to use it. So not only are there social marketing strategies, but it's important to really consider the overall communication and the goals of the interventions of the data we seek to understand. And understanding not only the data, but the target population, what's relevant and practical to them. So the content we create with the data that we use and moving forward, particularly with policies, implementing practical solutions to dilemmas that are still out there, are going to need the data. And I think between the contacting, communicating, the core questions that need to be asked of the data that we have collected, and able to collaborate with that data with other pieces, and closing the loop at the end of the game, what are we going to want to accomplish? So we have a very exciting panel and very frontline and really has walked the walk. So we're very excited about this session. I'm going to first turn it over to Ryan Smith and Stephanie Spriggs, who are really going to talk about big data and baked goods, making the Colorado all-payer claims database approachable. And that's the really key word here, approachable. So with that, we will start our presentation.
Hi, welcome to our presentation, Big Data and Baked Goods, Making the Colorado All-Payer Claims Database Approachable. That title makes me giggle every time I say it. Ryan, do you want to introduce us so we can get to the baked goods?
Sure, Steph. It would be my pleasure. We're the Center for Improving Value in Healthcare, or CIVIC for all you acronym lovers out there. We're an independent nonprofit that equips partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. And we're responsible for overseeing the Colorado All-Payer Claims Database, or COAPCD for short. So we've been around for a while now, over 10 years in fact. And one of CIVIC's many strengths is our diverse team, which brings together a wealth of backgrounds, experiences, and perspectives, all of which contribute to our well-known reputation for advancing data, creating knowledge, and improving lives. Ready to meet your presenters?
Yes.
Hi, everyone. I'm Ryan Smith, the in-house graphic designer here at CIVIC. I'm responsible for ensuring the consistency, tone, and overall aesthetic of the organization's visual content. What I enjoy most about my role here is having the opportunity to be a visual storyteller, not just with Civic's story, but the stories of the vast and complex data we're responsible for. My background is comprised of over 20 years of creative design experience, stemming back to my formative years as a game and level designer in the video game industry, to stints at various marketing agencies, and now in the nonprofit healthcare space here at Civic.
And I'm Stephanie Spriggs, Senior Communication and Marketing Manager here at Civic. I use words every day to amplify the activities of Civic and change agents in Colorado and across the nation. I've had a little bit of a weird career trajectory. I started as a stage manager in professional theater, and then I moved to coordinating janitorial services for restaurants. Neither of these prepared me for my time here in healthcare data. But on the whole, I think our lack of background in what we're supposed to be experts in actually helps Ryan and I. It makes it easy for us to put ourselves in the shoes of our audience and experience what we do from an outside perspective. It also helped us shape our goals for today's discussion. So today, we want to call out challenges that exist when attempting to make big data and analytics approachable to the largest possible audience. We want to share the strategies we use to explain complex and abstract concepts in relatable and concrete ways. And we want to kickstart much needed conversations about accessible and inclusive communications in the world of health data and analytics. And conversation may have had the biggest impact on this project. Communication can't happen without communication. The simple ability to bounce ideas off each other while working toward a common goal was invaluable and helped Ryan and I tackle this challenge that Ryan's going to explain.
That's exactly right, Steph. For us to even begin to identify our challenges in communicating big data and analytics and ultimately overcome those challenges, it was imperative that we be able to communicate with each other. Fortunately, that came naturally, and we were able to begin our work right away. Each year, Civic is required to report to the Colorado General Assembly on the administration of the COAPCD. Upon reviewing our past reports and centering our conversations around our audience's needs, we recognize several significant shortcomings in our approach. Our previous reports suffered from density and complexity, presenting readers with walls of text and a lack of structure. We often delve too deeply into the technical aspect of data and analytics, making the content intimidating and inaccessible to many readers. To put it simply, we weren't communicating with our audience in a way that was meeting their needs.
For all Civic's innovation and achievements, no one could understand what Civic accomplished. And we were consistently excluding and alienating those we most wanted to work with. Engaging with data shouldn't be hard. This isn't a secret club with a secret handshake. Everyone should have the information and power they need to make good decisions. We wanted our report to open doors, not close them. So today we're sharing 3 of our strategies and how they transform the way Civic communicates and engages with our audience.
It's true. Everyone should have the information and power they need to make good decisions. With that said, our first strategy was put the readers first. When drafting the 2022 COAPCD annual report, we made sure the fundamental principle of placing our readers first was at the forefront. We firmly believe that data gains significance when placed in context and made relatable. We were committed to ensuring our readers felt welcomed and supported by Civic when engaging with the report. We made this commitment explicit. By doing away with dense walls of text, adopting simpler language, and implementing a thoughtful layout with clear hierarchy, we positioned our readers as partners, welcomed them to our community, and showed how we could support them. By incorporating accessible elements into the report, we leverage relatable graphics and iconography to enhance engagement and facilitate easier comprehension of the content. Our audience's needs were paramount, so we ensured that the report offered accessibility, not just at the surface level, but also by providing clear callouts with links for those who desired deeper insights. Furthermore, we maintained a keen focus on optimizing the user experience, ensuring ample white space in the design to allow the content to breathe and granting readers the ability to swiftly navigate and absorb the information.
Our next strategy was to meet our readers where they are. We knew that for any of our readers to grasp the achievements and innovations we had made in the last year, we had to help them recognize why they mattered. Our goal was to explain Civic and the co-APCD in language that was easier to understand and inclusive of more readers. So we brought the language in the report from requiring a PhD to needing a high school diploma to understand. The tool we used was the Flesch-Kincaid Readability Assessment Tool, which is available in Microsoft Word, and it helped us adjust the reading level required to understand the report.
Our third strategy was that we trusted them to follow where we led. Describing the COAPCD is a constant challenge. Often, our discussions become heavily focused on the complex technical aspects of data collection and processing, leaving limited space to illustrate the ways in which we provide support to those we serve. Our goal was to develop a suitcase analogy that can encapsulate the entire process from start to finish, providing a comprehensive reference point for use as needed. Big data and baked goods. As mentioned earlier, explaining how the COAPCD does what it does is often very technical and can be difficult to follow. This illustration is intended to make the system a little easier to understand. Step 1, sowing seeds. When insured Coloradans visit a doctor, their providers submit claims much like planting seeds. Step 2, a plentiful harvest. Health insurance companies act as farmers, gathering these claims and storing them in a communal silo managed by Civic. Step 3, a collective resource. The silo represents the COAPCD with Civic overseeing it while processing the collected grain into community usable flour. Step 4, guaranteeing good grain. Civic tests the grain to make sure it's good before processing, storing, or turning it into flour. Bakers, like COAPCD data users, need high-quality ingredients. Step 5, assisting individual efforts. When bakers, COAPCD data users, require specific types and quantities of flour data, they turn to Civic for assistance. Step 6, supporting the community. Civic also utilizes the flour to create various baked goods, which are shared with the community at no cost, mirroring public COAPCD data releases on civic.org. So naturally, we were a little nervous, since what the heck do grain and baked goods have to do with claims data? But we've heard from internal and external folks that the grain graphic has been incredibly helpful in explaining and understanding the COAPCD. This brings us to our takeaways. Steph?
Thanks, Ryan. So here are the big takeaways and lessons learned from our experience with putting together this report. First of all, it is more important to be understood than to be the smartest person in the room. A fearless analogy can take something from the abstract to the concrete in an instant. Big data isn't always gluten-free. Effective and compelling communication about data and analytics is one of the most crucial ways that organizations like Civic can reach our partners and make new ones. This work is vitally important, but we will only be successful if everyone is at the table.
That is why we want to continue the conversation. Civic's hope is to open and advance the conversation about the significance and accessible and inclusive communications in the specialized world of health data and analytics. We're eager to engage with you to explore the strategies and hurdles you encounter in this space. If you're interested in exchanging ideas on how we can collaborate to make our work more accessible to a broader audience, please don't hesitate to reach out to either of us. We appreciate everyone who joined us today and look forward to continuing this conversation with you.
Thank you, Ryan and Stephanie. That was absolutely fantastic. And it brought home the very important point of we have all this great data, but how do we make people understand it? And the audience that you're talking to, what do they need to get out of it? So thank you for that phenomenal, really down-to-earth, practical thought process that we really need to get to. Because not all of us are, astrophysicists or techno wizards, and we need to still understand. So thank you so much. Our next group of subject matter experts are going to talk about the growing opportunities for value-based care through optimizing oral health data quality. Carolyn McLeod, Rebecca Matthews, and Loria Davis are really going to zoom in on this. And this is also likewise going to be really addressing some of the core questions and closing the loop as we continue to move forward in data communication. So take it away, Carolyn, Rebecca, and Loria.
We are excited to be here with you today to talk about growing opportunities for value-based care through optimizing oral health data quality. My name is Caroline McLeod, and I am with CareQuest Institute. Today, we're going to explore the value and processes of optimized oral health data collection and utility in support of equitable healthcare transformation. And the testing grounds for this value exploration is the Community Oral Health Transformation Initiative. This was an initiative developed by CareQuest Institute that's really designed to bring oral health into the fold of value-based care, which is a healthcare-wide transformation effort focused on improving care quality and health outcomes while lowering the cost of care. CareQuest Institute works with in-state organizations and safety net dental clinics to implement the initiative locally, supporting them with tools and resources for improved preventive and integrated care in their own communities. This initiative began in 2020 in Massachusetts and has since grown to include partners in Ohio, Arizona, Michigan, and most recently North Carolina. And we're going to focus on the North Carolina experience today. In North Carolina, a partnership between the North Carolina Oral Health Collaborative, CareQuest Institute, and Blue Cross Blue Shield of North Carolina Foundation aims to improve statewide readiness for value-based care and oral health using data to inform decision-making and transformation. Participating clinics in the initiative work to collect and report quality data following a core set of oral health quality measures. And this measurement really does empower them and their healthcare teams to track progress towards goals, change behavior, and improve care integration and value. Additionally, as clinics report quality data, they receive incentive dollars for doing so. The process that we've used for optimizing data collection and utility is showcased on the screen. So participating clinics securely report a variety of data from their electronic dental records to CareQuest Institute. And then CareQuest Institute inputs data into an interactive dashboard of quality measures for each clinic, and they determine data quality scores. Clinics then receive their dashboard updates monthly and receive incentive dollars for reporting quality data.
Hello, I am Loria Davis. I am the Clinical Dental Manager of Piedmont Health Services, and I am here to share our experience being part of the court initiative. Part of being a participant of the court experience is being a part of something innovative and unique in the way that we practice, in the way that we see and serve our patients. How do we do this? So Piedmont Health Services, we have 5 brick and mortar locations, 1 mobile health unit, 2 PACE, all-inclusive healthcare for the elderly, as well as a homeless location. Part of the court initiative involves us to be able to track the data of what we do through minimally invasive procedures, teledental, as well as integrated medicine. We're able to track our data. We're able to see what we do. We're able to compare this information to other sites to determine how we can make improvements on best practices on how we deliver care. This comes from things in the future on how we can make better improvement goals and objectives for the future of our patients in dentistry.
Thanks, Loria. And hi, everyone. I'm Rebecca Matthews with CareQuest Institute. It's great to hear about the experience from Piedmont's perspective. And to take a step back, I want to look at the big picture of how data is empowering transformation. So Deming said that the ultimate purpose of collecting data is to provide the basis for action or for a recommendation. The visual you see here might look familiar to improvement experts, implementation scientists, and researchers. The same process that we use for moving from theory to evidence-based recommendations applies at the micro level in a practice like Piedmont Health Services. to drive their data decisions, while also at the meso or macro level to build evidence supporting policy change. The framework here wasn't borrowed from, say, Institute of Healthcare Improvement. It's drawn actually from the state of Colorado's annual budget process, where an evidence continuum is required to justify funding through a demonstration of effectiveness. So I really think this gives us an intriguing pathway to look at the progression of data to informing evidence and then to driving action through policy. So we utilize this framework at CareQuest Institute in our program evaluation. It is active in the court initiative in North Carolina. And so as we think about the shaping of an outcome evaluation to maximize impact, we should be focusing on ensuring that the data we collect and report is providing clear and compelling evidence to demonstrate what the need is and what the problem is that's being solved. To also present policymakers and decision makers with high quality and to contextualize data about their communities and their constituents. And then finally, to demonstrate how the community's input can really help to lead to more impactful programs. So thanks for your time today.
Thank you so much, Caroline and Rebecca and Loria. I think it really brings to the point that if we have data, we need to close the loop. And I think as we move forward and we continue to realize just how so much data is out there, and so many answers could be answered if we understood it and how it's presented. I think we really could change a lot of trajectories that are maybe off the rail in what we're seeing today in care delivery. I do want to say one thing. I do see questions in the chat box. We will hold them to the end so that perhaps a question that's directed specifically to one of the presenting teams, maybe one of the other teams likewise has some response to it. So please note that we see your questions and we will definitely get to them. Our third presenter is Juan Zhang, and he is going to talk about the methods and deduplication of member eligibility data. I think this is extremely important because deduplication is something many institutions, organizations, we all struggle with data. And I think methods to improve, optimize, eliminate are very invaluable as we move forward. So, Jan, do you want to go forward? And please go ahead.
Hello, everyone. This is Yuan Zhang from Human Services Research Institute. The topic of my presentation today is methods in deduplication of member eligibility data. As we work on APCD data, the member eligibility data is an essential part. It contains information on every covered plan member during a reporting period, and it includes some important fields as shown on the slides, such as payer code, insurance product type, eligible month and year, member ID, and some important person information. Typically, each eligibility record submitted to an APCD on a member month level. If not, they undergo a data warehouse process to restructure them into that format. So the first SNP is an example of the eligible records in member month plan level, with the member and 1 month coverage in one row. The second SNP is the example of the eligible record not in that format, with the member and the coverage period from the plan effective date to plan termination date, so that one row includes more than 1 covered month. The accuracy of member eligibility data reflects a high quality of APCD data. Eligible member volume reflects the size of the health plan. Duplications will have negative impact on any data report that is based on the eligibility data. There are some important calculations that involve eligibility data, such as the PMPM calculation is the total allowed amount divided by total eligible members, and also the member match rate calculation is very important. Sometimes the duplicate records are exact duplicates, and sometimes there are minor differences on certain fields. Sometimes payers submit more than one member month record per month. This does not necessarily mean duplicate. Further analysis is needed. Therefore, it is important and also challenging to detect and resolve the duplicate eligibility issues. There are some common types, detection, and resolution methods. Type 1 is duplicate in major fields. We first define a set of most important fields as duplicate identifiers, like some are shown in our earlier slide. And when the two eligibility records contain the same values of the duplicate identifier fields, they will be identified as duplicate. It could be either fully duplicate, like all the fields are the same, or it could be like have the same values of duplicate identifier, but different values in the non-duplicate identifier fields. Based on the nature of this type, it's feasible to have tools or scripts to automatically detect this issue. HSRI deduplication process has been created to catch the duplicates and only keep one record for the duplicate sets to the next step. Type 2 is same member ID, different values in duplicate identifiers. During the HSRI QC process, the duplicate checks on eligibility data are applied by checking if there's multiple rows per member, payer, year, and month for each coverage type. When there's shift in the potential duplicate records, details will be investigated for this payer. Here is an example. From the SNP, we can see the set of duplicates contain the same member ID, the important person information, and other key fields, but with different insurance product type, different coverage flags, and plan effective days. During the QC, HSRI found this issue and we communicated with the client and the payer. The payer confirmed that they generated multiple individual records for the same member because data submitter A and data submitter B combined data and began submitting under data submitter C starting the month of August 2020. So as we confirmed with the payer and they provided the resolution is that they will resubmit the correct data to resolve this issue. Another example which looks pretty much similar with the above one, the duplicates contain the same member ID and the same person information, so all the 4 rows are for one member, 1 month, and year. But we can see they have different insurance product types and different coverage flags. During the duplicate quality check, HSRI detected that there are multiple rows per member per month for this payer. After communication with client and payer, we found that this is due to there are 2 data submitters for this payer, and each submits a separate dental eligibility file with dental IPT and dental coverage. So that the first row with an IPT DPPO, which is the dental version of the IPT PPO, and it's also shown in the coverage flag. So the payer confirmed the accuracy of the data, and we detected that there's no further quality issues, like it won't increase the distinct member count, and the different IPT will match to its according claims. So the resolution for this issue is that no further step is needed. We'll keep the data as what it is. The type 3 is different member ID, same value in duplicate identifiers. This is a very tricky type since the member ID for duplicate sets are different, and it cannot be detected by multiple rows per member per month. It can be detected through the unexpected inflation of distinct member counts, which reflects in unexpected low PMPM. But if the duplicate issue occurs for several months, this type of duplicate is hard to be caught since member ID is the crucial field to identify the duplicate issue. In this example, the first 2 rows are with the same date of birth, first name, street address, but different member ID, subscriber contract number, and different coverage flag. One record, we'll see the second record, the highlighted record with only pharmacy coverage, and the other one with all the other coverages. And the third and fourth row are in the same situation. This issue was detected by the payer after reviewing the annual validation report. There were 2 data submitters submitting at the same time to one payer, and one is only for pharmacy coverage. So finally, the payer decided to split the payer into 2 payers with a separate payer code for the pharmacy-only coverage submission. This resolution is completed by data remediation through creating a new payer code and assign them to the according eligibility record. We can conclude that the main resolutions for the member eligibility deduplication is first, analyzing the issue, reviewing if there's other quality issue exists for the same payer and period, and then communicate with client and payer. We can apply the resolutions as follows. So first is the data remediation. When you can find a pattern for the duplicates, we can remove the records with the same pattern or change the values with certain rules. Then resubmission, if there's no easy way to apply the data remediate, or if the payer is willing to do that. And the third is nothing is needed. We'll leave it as long as there's no other quality issue and is approved by the client and the data submitter. Now we've talked about the types, examples, detection, and resolutions. It suggests that the duplicate issue of member eligibility data commonly happens, especially when there are multiple data submitters for a payer. In our role as data processors, we have implemented checks either processed by automation scripts or reviewed by analysts to identify and address the issue. Particularly during the payer combination or division occurs, we will pay extra attention to detect the potential duplicate issues. We will proactively gather information and explore the best resolutions. And for the states, it is very helpful to encourage payers to follow state submission rules when submitting the eligibility data, especially for those payers with multiple data submitters. Providing reports, such as annual validation report, to payers proved to be an effective way to enabling them to compare their submissions with our records and then helping in detection of duplicate eligibility issue. Furthermore, we greatly appreciate the important role that states play in bridging the connection between data submitters and the data processors. Thank you. Let me know if you have any questions, comments, and concerns.
Jan, so much for that presentation. You know, it brings me back to Ryan and Stephanie's presentation of the ability to know your audience and how to get your point across from those various pieces that we have to understand, and how can we get a complex conversation to its most simplest form, such as what Jan just described. I am very impressed. I must tell you that my skill set is less than optimal when I was going through some of the steps, and that's an example of, you know, a learning curve given staff shortages. Given that we want to retain employees, it's really important to be able to level set our communication, our data points. So thank you for that. And now what I'd like to do, first and foremost, if you have any questions, please put them in the chat. And we're going to go through them now. The first ones that came up were for Ryan and Stephanie, and it is from Katie. And can you describe the process for developing your graphics, the brainstorming process, who's involved, iterating it, etc.? So that's for Ryan and Stephanie. Can you go for that one?
Sure. Well, my guess is that you're asking about the grain graphic itself. The larger analogy came from brainstorming. I brainstormed with our current CEO, Kristen Paulson, to work out the whole idea for the ABCD as a silo. And then I proposed it to Ryan and said, so I have this wacky idea and I need you to make it real.
Yeah, so That was a lot of fun. But yeah, I mean, first it just started with identifying that we had a challenge in communicating what we do and how we work with the data. And from that, we started, thinking of solutions to, solve that challenge. And yeah, once we had the analogy, it was basically refining that language. On my end, I worked heavily with the graphics and layout. So it was really being conscious of, design principles and, maintaining our brand standards with our color palette and so on. And, really as we developed it and things kind of came to fruition, it was just, a number of sessions of us reviewing it and refining it and ultimately finishing it.
Breaking it down into the smallest number of components so it was easiest to understand for the process itself.
And I think that brings it back to the point, know your audience. You bring it to a level where, and oftentimes you're in an audience where, or you're a presenter, or you're trying to get a point across, and you don't know actually the capabilities of the audience. Not that it is, it's just the skill set that hasn't been fine-tuned yet. And I always tell everyone, don't worry about a title of someone, the C-suite, the director, whatever. It's the ability to understand and bring that to the next level. And I guess the follow-up question, Ryan and Stephanie, is, with all our cross-cultural communications, Alexis was questioning, or in other languages for your communities to understand the work. There's pockets of zip codes where certain nationalities gravitate together for support. And we track that oftentimes, through zip codes. Do you do any work with that cross-culturally? And if so, does this also, this presentation come in other languages so that you present it in the actual language of the person you are wanting to get the point across?
Civic just began working to branch out in that way. This past year, we have our Shop for Care tool that is one of our flagship pieces of analytics on civic.org, and we translated it last year into Spanish. We've also done a few other little analyses in Spanish, and it's something that we're working towards gradually. And it's one of our larger goals in the JEDI DEI world. We recognize that in order to be inclusive, we have to spread our wings and make it available to everybody. It's also a big challenge for us as communicators to reach as many people as possible. And it's why we would love some help reaching out to people who communicate the same things that we do. And we'd love to hear from folks if they would like to get together and discuss the challenges.
And I think the English language has slang, and many of the other languages are very prim and proper. So I think adding that little layer of something that sort of puts a little monkey wrench into things makes it harder to translate into languages, and it shouldn't have to, but it's just our ability to modify and a little bit of tweaking through slang our messages, and that sometimes is very hard to be translated into an otherwise what we would think is a similar level of language use. I just want to jump around a little bit. We got one more question for y'all, but I want to get to Kenley's question of to Jan. How do you address or reconcile the data if the submitter can't correct or realign the coverage flags? In a very short, concise answer, how do you do that?
Well, usually we would expect the payer to know their data, what is the correct way to look like, and how the data has been submitted, how the data has been processed. And we will try our best to not only detect the issue, but also we'll find the root cause, which fields cause the issue, and we'll provide the suggested resolutions. And maybe one, you can do data remediations, or for resubmit the data, what is the better way? And if the payer still find it's hard to resolve the issue, we'll have messages sent to them, or we can definitely schedule meetings and communications with them, and we'll work together and to resolve the issue.
And just as a follow-up, have you considered using the master data management, especially for your third example that you provided, where the member IDs are different?
I think this is a very good suggestion. The master data management, I would like to know more about that. But for us, like the third example, when the member IDs are different, it could be hard to identify the duplicates. But we'll, like, from the example is identified by the payer, they think the counts is more than they do. But it's hard to detect because not only in the eligibility files, but also in the claim files, the members they match, they have like two sets of members in both eligibility files and the claim files, and they match and they have similar counts. So it's pretty hard to do from the QC side. But I really like to know the master data management methods and if there's a better way to detect those issues.
And if Betty has any further questions, she could definitely reach to you and continue the discussion. And I want everyone to know all of our speakers are very open to connecting with you. We are all very passionate about supporting the NATO mission. Again, it's all about the data, right? You can collect data, eons and eons of it, but if it's not relevant, it's not helping, it's not moving us forward, it just sits there. And then eventually it gets stagnant and useless. And that's counterproductive and really counterintuitive to healthcare, because healthcare is an ever-growing field to get everyone to the next level. I'm going to jump around a little bit, and I'm going to ask our second group of really trying to figure out, Caroline, Rebecca, Loria, when Emily wants to know, when communicating with the clinics report data, were all responsive to the incentive plan, or were there challenges in getting the clinics and people on board? When we started EHRs, for instance, we always had to zoom in on a champion or a very popular person in the group that would sort of muscle people down that were, having difficulty accepting change. Did you all find, any type of challenge? And if you did, how did you react and respond to that?
Thank you for that question. We really appreciate it. And I would say, in short, all the clinics that we were participating in our program were really responsive to the incentive. They were excited to be getting some extra money for reporting data. I will say, though, we did go through an onboarding process, and we found that luckily, because we were a pilot project, we worked with only 13 dental clinics, so it was rather small to begin with. And so we were able to do an initial kickoff call with all the clinics to explain this is what we're doing and why. And that really helped, from my perspective, to get buy-in to, okay, we're going to have to work towards collecting data in a way that, the program is asking for in a good quality manner. But the buy-in was there pretty much from the beginning. And with onboarding, we met with each clinic one-on-one to explain, what we expected of them, and to go through just instructions and help them put their reports together to submit. And we found that to be a really easy way to communicate with the teams and have them communicate with us. And we met primarily with one or two people from each clinic that were known as the data champions or data managers. And so they were more well equipped than maybe others in their clinic to handle this type of reporting. And the cool part is that we have one of our providers, one of our data champions here, and that's La'Aria. So it's cool that we get both perspectives. So I'd love to ask her kind of her perspective. Was it easy to buy into, or did you find things difficult?
Very good question. And I'm not quite sure. Can everyone hear me okay? Okay, fantastic. I found initially everyone challenges with change, but once they realized the incentive portion of it, the payout portion of it, then we had buy-in. We did also have to have champions at each site, and also we met on a regular basis and reported and showed our sites what we did. Come to find out, people are competitive. So I found it to be more of an incentive, because then it became competition between the sites. They wanted to see what they did and then develop strategies on how to make improvement strategies to enhance the previous reporting that we've done. So initially I would say yes, but now I get a lot of questions on what we need to do now. The incentive piece was very nice. So everyone likes new technology. We've also used some of the funds for some retreats and some incentives in-house. So that also helped kind of change the perspective to get the buy-in champions and cultivate the change we needed on the clinical level.
And if I could add one more thing, and then I promise we're done, Helen. I would say too that the dental clinics, several were using the same electronic dental record. And we had one clinic who had a lot of support with IT staff and got their reports done, I mean, within days of us asking for them in the first place. And they were actually able to write out step-by-step instructions that we were able to share with some of the other clinics. So it was almost like, one clinic had a lot of support and they were able to share their support with other clinics, and it made it much easier on the others that shared the same system.
Fantastic. And, at the end of the day, it takes, the old saying, it takes a village to build a team. And if you have one person who's sort of the outlier, I think they sort of get ganged up on eventually, because it holds everybody else who's interested in moving forward. So eventually peer pressure, I think, sort of caves in the obstructionists eventually. So thank you for those thoughts. I want to go back to the first presentation. It was very interesting because you were able to identify what level of education that you needed to communicate with. So Emily wanted to know, was the Flesch-Kincaid readability tool supplemented by any of your other resources for adjusting the reading comprehension level on your report? Can you respond to that?
Absolutely. We would love to say yes, but no. We use the Flesch-Kincaid scale mainly because it was the most accessible and easiest tool to use out of the box, because it is built into Microsoft Word as part of its editor proofing capabilities. There are other tools out there, but they're not as easy to use. And we didn't want to make perfect be the enemy of the good. We would rather move forward with imperfect tools. But we also recognize there are a whole bunch of other resources out there. And if other folks know about them, we would love to hear. And I think this is where as people who are communicating in an industry that's kind of specialized, we all have similar challenges, and it's where we can help each other. So I wish I could give you better resources to help, but if we all come together, we can pool our knowledge.
And I think, being able, it's not an insult. It's not condescending. Oftentimes people don't have English as their first language. They're learning it. They are fast studies. But even when I lecture at the university level, I always try to get it to an 8th grade level of English. Personally, my vocabulary is very weak. I'm a pharmacist by trade. They never taught us English. They taught us, math and science. So some people are more challenged than others, understanding a concept that otherwise, if it was in simpler terms, would be understood, and then they could execute it and bring it into the fields where we need it. So I guess it's always a challenge. And I think we got to be sensitive, again, to the audience, what we want to accomplish. We don't need to boil the ocean, but if we could start boiling the puddles, that moves us closer to where we need to be in a realistic approach.
Absolutely. And that's a lot of what Ryan did as well, because what I couldn't do with the language, Ryan brought in with the graphics in the design of the report. So it was a multi-pronged strategy.
Yeah. And I think infographics are very powerful. You could read a paragraph and not understand it, but see a visual. Visuals are hugely underestimated of bringing in a really complicated concept front and center. So I encourage the audience, if you don't know who you're presenting to, and again, titles are irrelevant. It's the person who needs to execute. Of course, we have to respect everyone, but don't be misguided by a title thinking you think they know what you need to say. They may not. And we're finding that more and more because we want to bring people up from the trenches and reward them. And as you reward them, there's a learning curve, and we must appreciate that as professionals. Olga wants to ask you, Jan, for your presentation, what do you include in your annual validation reports to the payers?
HSRI created the annual validation reports based on the requests from the clients, so say the states, and every state they may have different requests on the reports, so measurements included in the reports. And generally, that's the summary information of the eligibility files and the claim files. And that could be for the past 1 year or the past 2 years or 3 years for comparison. Like for the eligibility counts, there could be the member counts by year and quarter, by coverage type, by line of business, and then by gender, by age group. So that's in several groups.
And I think for our presentation, Rebecca, Caroline, Loria, Sylvia just is making a statement saying about CareQuest use the concept of teledental. So used to only speaking about telehealth, teledental care is under study. Can you comment on that?
So as far as teledental, that's definitely a new concept. We're very lucky that it was a service that really resurrected back in 2020 during the time of COVID to figure out how we can still deliver access to care to people with acute dental needs during the time when they couldn't come in. Since then, it has evolved and has morphed. We too use teledental for when there's barriers to access with coordinating appointments for our on-site at our on-site level. We also use teledental for our interdisciplinary relationships, like with our IDT prenatal visits. We teledental right in so the patients can have a whole visit from the medical to dental, from behavior health to WIC, as well as pregnant moms, from the prenatals to the well child visits. So we try to find lots of ways to incorporate teledental, and I love it. It also helps for we have a all-inclusive healthcare for the elderly with your space. Sometimes it's a challenge with some of those patients. Sometimes teledental is just communicating best practices or belittling or getting rid of the barriers to being able to get access to the site, from transportation to even money, because the teledental visits are a little less expensive, and also able to handle these patients on an acute need and taking some of the pressures off the site level.
Yeah. One thing I'd add, Helen, just quickly, it's Rebecca, growing use of teledentistry was a key goal of the project. And, something in North Carolina was a big opportunity. Like Loria said, given some of the history of, coverage availability, reimbursement, and then policy allowances for teledental. It really is, as Loria just talked about, teledentistry has number of use cases like telehealth, like any other, thinking of telehealth as a communication modality. And so having practices really kind of focus on the use cases that work for them and their populations is fantastic to set some goals and to grow the utilization within this project. And then two, to be able to kind of track how is that allowing for extended access to care? How is that relating to, workforce capabilities within the health department and so forth? So there's a lot of places where, looking at the goal of utilizing teledentistry, then applying it to that practice's, population needs can allow for a lot of learnings and, insights that relate to goals for increasing access, but then also how that can help to translate into the, that individual practice's workforce.
But, you know, Rebecca, just to challenge your thought for a second, you know, dental is more of a hands-on, you know, like how do you know if a tooth's infected, or, you know, like simple things. And on the other end, if they don't have an adequate iPhone or something, you know, is it also to a point where it might do a disservice for someone? So are there protocols with which you say, nope, this is not a telehealth opportunity. I got to see you? Because some people just may say, gee, my tooth hurts or my jaw hurts. And it's so subjective. I just want to get your sense of that.
Yeah, and I'd love for my clinician colleagues to weigh in too. But, you know, what you talked about was basically triaging. And so, you know, there is an ability if, you know, we're dealing with a toothache or some sort of concern, for communication to really help a clinician in discussion with the patient to figure out, is this urgent? Is it emergent? Or, you know, should we look at having an in-person evaluation, you know, within a day or two? So I think that's where, in terms of like scheduling and, you know, triaging needs, the value can come. And that way, in a way that is, you know, benefiting the patient, could help to set them at ease to know the level of urgency if we're, you know, talking about a toothache.
And Gloria, you wanted to add to that?
Yes, I did. And to Rebecca's point, it is a lot of triaging, for sure. But one good thing is once the situation is triaged, then we're able to allocate the proper amount of time. A lot of times when people are using these teledental platforms, like outside of traditional work hours on a Friday or Saturday, and you look at them and their face is, you know, looks 3D, because you know they need antibiotic before we do services, that helps them in real time. Yes, they do need an on-site visit most of the time, but, you know, a lot of times not as well. Sometimes it's just a matter of, believe it or not, for our pregnancy moms, for example, you know, there's a lot of bleeding with pregnancy, and patients don't know that they're pregnant and they're wondering why all this blood is coming out of their mouths. Sometimes it's just education as well, and letting them, you know, swelter down their fears of what's going on in our mouths. However, yes, most likely there is always an on-site visit that follows a teledental visit, but it's a great way to give people those alternative ways to get care. And also sometimes it's just a conversation to really help people feel more comfortable about what to be expected, especially when they're in pain or discomfort.
Yeah, and I'll add one more brief thing to that one of my favorite models for teledentistry is actually where dental assistants and dental hygienists will go out into community settings, whether that's a Head Start program, a school, a nursing home, a long-term care facility, where a lot of times these populations may not actually be able to get to the office, and they'll provide them preventive services like dental cleaning, fluoride, education, and then they will take all their assessment data, like x-rays, their charting. They'll take a lot of photographs of inside the mouth, and then they'll actually send all those assessment pieces to the dentist who's in another location to do the dental exam. So you have really widened access to care that these populations have using teledentistry. And there's quite a bit of research out there showing that a virtual exam by a dentist is just as good as an in-person tactile exam by a dentist. So I want to make sure that model is highlighted as well.
And I think our data is showing more and more that, you know, preventive care. I don't know the last time I bought a toothbrush, because every time I purposely go to the dentist just like get the expensive toothbrush. So I jest, but basically it's those freebies that really count. So in any event, we're timing this out. And all of our speakers are, again, very eager to communicate with you. You have their emails. If you have any further questions, please send them to Norm and Charles, and we would be happy to continue the discussion. I'm going to give 2 minutes back so that you can get to the next session. We thank so much Norm, Thurston, Charles, Harley for helping us and really putting on a phenomenal educational program. So with that, we'll close out, and we hope you have a great rest of the day. And don't forget, we have tomorrow's session and Thursday's session. So we're very excited. This is just the beginning of some really great discussion. So make sure you get everybody linked together, and let's do something great, all of us.